Jacqueline, thank you so much for coming on today. Now, I'm going straight into it. You've assessed thousands of people for PIP. And I'll be honest, that's a question lots of people are asking. So I want to pick your brains on that straight off. Tell me all about PIP and what the assessment involves, in particular if there's anything around fibromyalgia, because I know a lot of people are getting assessed for fibromyalgia and getting rejected.
Absolutely. So yes, I worked as a PIP assessor for a period of 2 years. And during that time, saw many, many people with fibromyalgia. So PIP is personal independence payment. So this is a benefit. It's not means tested. Anybody can apply for it. And the benefit is about the impact that a diagnosis has, not the diagnosis. So, for instance, you could have somebody with osteoarthritis in the hip, and they could be wheelchair bound, or you could have somebody with the same diagnosis who is actually an Olympic athlete. It's how that diagnosis impacts the person.
I see.
And their activities of daily living. So there are 10 activities of daily living, and then 2 to do with mobility and planning a journey. So it's how it impacts. And anybody can apply for it, whether you're working or not working.
Okay, interesting. How do you, because you've actually assessed people, right? You're an assessor. So what does it involve? So is it in a room like this? Is it questions, is it examination? Is it what? So
somebody would apply for the benefit, and they'd get a really in-depth questionnaire, which is so off-putting to begin with, particularly if you've got something like fibromyalgia, where you have fibromyalgia fog. So you're going to have difficulty filling the form in anyway. So what they're looking for, so it's a massive form to be filled in, and then that goes off to be assessed, and then evidence needs to go with that form. If people don't put evidence in, it's going to get rejected straight away. So it's then looked at if they can do it as a paper assessment, and if there's enough evidence, so you need evidence of what your diagnosis is, what treatment you're having, what medication there is, what the side effects are to the medication. If all of that's included in it, and it's very clear, then they can do a paper assessment where they'll score it, and you'll get an award. If not, it goes to an assessor. So I would be, as an assessor, I would log onto my laptop at night, and I'd get 5 cases come through with all the evidence that comes with it. So I would either be working in the field, where I would go out and see people in their homes who were deemed that couldn't travel to an assessment centre.
Okay.
Or they'd be invited to go to an office where I'd see them in person and do the assessment. So the assessment is going through the questions and asking the evidence. And there's also a physical assessment, a very simple one, where you're asked to stand up, put your hands above your head, etc. So it's in person. I personally believe every assessment should be in person. None of them should be paper. If they can clearly score high in all areas, absolutely. But everybody else should attend an assessment, because lots of information is missing. I'll give you, for instance, if you somebody with fibromyalgia, typically they have stiffness and chronic pain. They'll put on the toileting that they've got no issue with toileting. No, and I'm fine with toileting. Okay, then. So I'm looking at somebody who's got chronic pain, very unwell. And you ask them, okay, go through then. Can you get on and off the toilet? Okay. Oh, yeah. It's okay. How do you do that then? Well, there's a radiator next to me. And in the winter, I have to have a towel on it so I can push myself up with the radiator. And during the summer, I'm okay. But my husband's told me off a couple of times because I've pulled the radiator off the wall. So therefore, they're not okay. But they think they're okay because they can get on and off the toilet. So therefore, they need an aid. So, but you wouldn't know that unless you actually got talking to somebody and to understand exactly what's happening. So that person would have missed out on their scoring.
Okay, so this seems a bit of a unfair way of doing it, because I guess with fibromyalgia in particular, and I've seen patients who have got debilitating fibromyalgia who've applied for this and have not got it for various reasons, either because there's no one to help them do the form, and the form's long because they've brought it in to appointment and said, look, this form's long, what can I do? And on the NHS in 10 minutes, there's not enough time to go through the form because it's taking 8 hours, right? So the form's very long, and what you're saying is if there's information missing, they'll reject it straight away.
Yes.
So say if someone says they've got fibromyalgia, what kind of information do they need? Evidence do they need? Sorry. So I'm guessing they need a diagnosis from their doctor on a evidence of that.
Yes.
And any appointments from rheumatologists, blood results, scans, that kind of stuff.
Yeah.
Is that
yeah.
Okay?
Yeah. So and then evidence about what kind of aids and things that they're using. So a lot of things people are using that they don't realise that are actually aids. So when you talk to somebody about when they're preparing food, and you say, okay, so you're okay to stand. You stand there and peel your potatoes. You say you're okay. Oh, no, I have to sit down. So a perching stool is an aid. If somebody has to sit down, then that's evidence that they need to use an aid. Because carry out any activity, you have to be able to do it safely, within within an acceptable amount of time, and to be able to do it repeatedly. So when somebody's cooking a meal, preparing a meal, they can't do it repeatedly. You notice with fibromyalgia, they have a very poor diet because they'll be able to cook from fresh ingredients maybe twice a week, and the rest of the time they're eating fast foods. So that's not reliably cooking fresh from fresh food. So what we're looking for is evidence of tools that they use to help them. So whether it's an electric can opener, so it's evidence that they've purchased a can opener, and other tools that they use as well.
I see. So the evidence can be for something they have to order like a stool to sit down on. That can be so. It can be just a photo they can take and upload it. And guessing that's the same sort of thing, is it?
Yeah. Take a photograph of your shower that's got your handle in it and everything to help. Yeah, that's evidence.
Okay. And who looks at it? So when people, I guess from my point of view, because I guess you need some. Obviously, you need some kind of understanding about the condition itself. So on the first kind of initial assessment, who looks at that? Is it just like a generic person who's looking at the tick boxes? Is it, or who assesses the first application? Because that's vital, I'd have thought. Because you need to know
whoever it was, because I work for Capita, whoever it is, the professionals in Capita, will look at that, score that, and decide whether it needs to go for further questioning or whether they can do it. So the roles that are actually looking at these are, you can be a paramedic, you can be a paramedic, you can be a nurse, as long as you're in a healthcare, so a paramedic in the healthcare, paramedic, nurse, that could be a mental health nurse, children's nurse, adult nurse. So you could be in a position where you have a physiotherapist looking at somebody who's dealing with cancer, because we're all deemed to be the same. And I disagree with that. It's very specialist areas that you need to be looking at, but we're all deemed to be professionals and looking at all areas.
That's interesting because PIP obviously covers it covers every lot, like mental health, cancer, cardiology, respiratory, rheumatology, whatever it is.
Yeah.
But what you're saying is all the application they get allocated irrespective of what the person's speciality is.
Yeah.
Okay, that's a problem, I thought. Because it doesn't.
Yeah, it is a problem. I would have something allocated to me that I've never even heard of. I'm having to get a dictionary out and say, what is this? What is this? And what are the symptoms to this? I would absolutely do my very best and would take advice from other people, but that shouldn't be happening. But it was.
I think that's absolutely crazy, actually, because I think because potentially there's flaws both ways, because people may potentially be getting the benefit when they don't need it.
Yeah.
But more worrying, there'll be lots of people who are clearly not able to do the things that would make them get this benefit, but they're not being assessed correctly at that very first stage, and they get thrown out. Okay, that's worrying. And then what about when, if they're deemed they need a further assessment, then they come in and see you basically, or you out and see them? So we'll go out and see them, or they come in, and we do the assessment the best way that we can with the information that they give, and then that gets sent back to be verified and scored. If they don't have the information they want, that report will get sent back to the assessor to be reworked. We'll say, where's the answer to this? Where's that? Where's the evidence for this? And then somebody else makes the decision. I see. So when someone comes, what kind of things do you look for? So let's say chronic pain, for example, but it could be anything. What would an in-person assessment look like? So say I've come to you, I've got back pain, or I've got widespread pain everywhere, and I've come in for an assessment. What kind of, how long does it take? What does it look like? Like, is it, obviously it's intimidating for the person, right, coming in, because it's very intimidating, right, because a lot's riding on on it, and that in itself I think is a problem. But it's almost like an interview, right? So
absolutely.
But for some people it's a lifeline, difference between getting food and not, potentially. So what does it involve? Is it
so let's do it. So if they come into the assessment, so for instance, I worked in Nottinghamshire, so there was an office in Nottingham. So they're booked in, they come in, there's a big waiting room, and there are chairs in that waiting room. Some have arms on, some don't, and they come in, they book in. And then when we go to collect them from reception, you would actually say, you're here for a PIP assessment, and is that okay if we do the assessment here? They say, yes, the assessment started. So what you're actually looking at is what chair have they sat in.
Oh, really?
Yeah, it starts right from when they walk through the door.
Oh,
So if they've walked past chairs with arms on and have gone to a chair that hasn't got arms on, then you would deem that, well, they haven't got that much of a problem getting out of a chair because they've chosen a chair that hasn't got arms on. When they come into the office, again, there are two chairs. One's a high back chair with arms on, one hasn't. So again, it's which chair do they choose to sit in?
That's really interesting.
So it starts right from the very beginning. So when you sit down and you ask for ID, so you're typing and you ask for ID, you don't get up, you put your hand out for the ID, and it's whether they get up, lean over, or can't lean over and give it to you.
Oh, really? So these are all
It starts
things.
right from the beginning.
I see all these little kind of extra cues you look for. That's very interesting. I guess some people call it sneaky, but I think is important, right? Because sometimes there will be a lot of people trying to play the system, but people that actually need it, like you're saying, would not be able to do that potentially, right? They'd be sitting on an arm of subconsciously because you know. Yeah. So what other things are there? Like interesting, like because it's interesting to see these things. Like so obviously there's the chair, there's the.
So when they walk
it's interesting
in,
to get an insight from you.
So I'm very honest.
Yeah, I can tell.
Yeah. So when they walk in and you ask them, is it okay if we start the assessment? The very first question I'll ask is, did you find us okay? And they'll tell me where they come from. Okay, so where did you travel from? Oh, I came from Tuxford today. Oh, okay then. There's an amazing Asda near Tuxford, and it got some saucepans on sale. And they still got on sale. When did you last go in Asda? And they've actually told me how often they go out and what they do before they've even sat down. They've told me when they last went to the supermarket, how often they go out. We've already covered a big chunk of it before they've even sat down, and they don't realise that that's an assessment.
Interesting.
But it goes both ways because I will, that's not just a negative thing, that's a positive thing. Because I will then, when we get on to the questionnaires about how often you're getting out, etc., they've already given me the information. They're not going out. They haven't been to a supermarket in such a long time. And more often than not, particularly with somebody with difficulties like fibromyalgia, they will tell you that they're okay. They're not okay because they're not going out. They think because they're choosing. There's a difference between I can't go out and I'm choosing not to go out. And they think they're choosing not to go out. But when you get down to the minutiae, it's not that they're not choosing. They've got severe anxiety. They're very unwell and they're avoiding going out, yet they've lost really, really important points on that assessment because they think they're choosing. They're not. So it goes both ways. It sounds very sneaky, but I've used that information more to support people to get the correct score than for it to go against them.
That's super interesting because you're subconsciously you're doing assessment rather than direct questioning, which can be taken. You can wrong both ways, right? Yeah. So that's super interesting. What? Yeah. So, and I'm guessing whilst they're there, you're looking at everything, right? Not just their answers, but sort of non-visual cues. How they're moving. And I'm guessing you have some sort of framework to ask, right? Or is it just completely up to you about?
No, it's a framework. It's a framework that you work through. Okay. Another part of the assessment is you do a very simple physical assessment. The wording, I can remember it now, it's word for word. Okay, so we're just going to do a few exercises and I'd like you to follow what I do, but I don't want you to hurt yourself in any way and I don't want you to push yourself in any way. If you can't do it, then just say so. So what I'd like you to do is to put your right hand on your shoulder and your other hand on the other shoulder. Look this way, look that way, arms up. That's like Simon Says. Arms up. Because they put on the form that they can wash their own hair or can't wash their own hair. So the game Simon Says, and you do it. So when I say arms up, they've put their arms up. Yet they've put on the form they can't wash their own hair and they can't put their arms up, but they've just done it. Or they'll say they are okay washing, and when I say put your arms up, they'll say I can't because I can only get it to here without it hurting. But you've told me that you can wash your hair, but now you can't put your arms up, so therefore your score needs to go up. So again, it goes both ways.
And do you call them out on that do you say it during the interview or do you just leave it, write it all down on notes? Because...
And I'll ask further questions.
You would, okay.
No, I'd ask further questions. I'd say, okay, you've put on your form that you can wash your own hair, but you're having difficulty putting your arms up. How often is that happening? And it needs to be happening more than half of the times. So you've got to be able to do something repeatedly, safely, in a reasonable amount of time. So when you ask them, well, how often is that happening that you can't put your arms up? And they say, oh, well, particularly with ladies, they'll tell you that they've changed their hairstyle. So they don't have to wash their hair more than once a week because they can't because of stiffness. But they haven't put that on the form.
See, there's some nuances to it, and I guess you're quite experienced in this. How many of these have you done? You said thousands.
Thousands.
So so you're obviously very experienced about knowing how to ask, because sometimes someone might say no or yes, but but that's to the direct question you're asking. There'd be other ways to ask it, right?
Yeah.
So I guess the issue is there'd be people who are not as experienced as you, I'm guessing, assessors who might be in the first, say, 100 cases, right? And they may just go by a direct question or not know yet how to answer the indirect questions, and they may score the person down when they may not need to, or vice versa. So I'm guessing there's a situation where you could have one person or two people exactly the same going to one assessor saying, yep, you meet the criteria, and one saying, no, you don't, sorry, you're rejected. And I think that's a massive problem, right? And you must have seen...
Absolutely, it's a massive problem. So just last week, I helped a lady who, and you think, how can this happen? She filled her PIP assessment in, and she was helped by Citizens Advice Bureau, and it came back as scored 0 in all areas. Nothing.
I mean, no
0.
problem at all. Okay.
Nothing at all. 0. Looked at it, spoke to the lady, understood exactly what was happening. We got the evidence for what was happening with her, and her predominant diagnosis is fibromyalgia, and she scored high. She scored 12 in both areas at that tribunal. How can you go from 0 to high in both?
So high, it's scored out of 12 domains, I'm guessing.
Yeah.
Okay.
Yeah.
So she went from 0 to...
To high. She was awarded high. There's 2 points to it. So you've got the 10 activities of daily living, and then the second area is for planning a journey and mobility.
Okay.
So she scored 0 in both.
Okay, so no problem. Okay, that's
they said nothing. She scored 0, no points. And then after we sat down and went through it and produced the evidence and did an accurate report, she scored 12. Went to high in both areas with a back payment of £13,000. And she deserved every penny of that. The poor lady.
I think it's from a doctor's perspective. I see a lot, honestly, not so much now because I predominantly do private work, but when I was the NHS work, so many people would come in and say, look, can you write a letter to say I've got this? And I do write a letter, but it honestly doesn't make much difference because often people don't know what to do once they fail. So you can write a letter saying, look, this patient has got this pain, it is affecting their life. But ultimately, it comes down to the assessment, right? Its
impact.
And how do you get, so if someone completely disagrees with their outcome, can everyone have a tribunal, or how does it go? Can they appeal it?
Oh, yeah, absolutely. Okay. Yeah, so you put in for your PIP and it's assessed and it's turned down, then you can appeal that. You appeal that and then it goes to a tribunal. The tribunal will have an independent doctor and other professionals on the panel that look, and you're able to put in further evidence for what the impact of that, the impact of your symptoms. It's like I say, if somebody's got osteoarthritis, as a GP, you can write a letter to say, yes, this person has osteoarthritis, but they're an Olympic runner. It's the impact. And
that's what we can't assess. That's the vital thing.
Yeah,
right?
It's the impact.
Yeah.
I mean, for instance, I've been contacted by somebody who said, I've just been diagnosed with depression. Can I apply for PIP? I said, yeah, you can apply, but you're not going to get it because there's no impact. You're on yes, you have low mood. Yes, you're on antidepressants. But what impact is that actually having on your life? What's it stopping you from doing? It's not stopping you from doing anything.
That's interesting. I think mental health is interesting because I think you probably know about this. There was the whole recently the big uproar about obviously the whole they're going to the Labour government's going to upheave the whole assessment and what is and what is not. And two of the biggest things they're looking to remove are kind of the mental health, depression, anxiety category, but also the chronic pain / fibromyalgia, which essentially is kind of conditions where there are real conditions, but it's hard to prove medically without a blood test, right? I mean, for a neurological problem, you can likely prove it with a scan or something like that.
Yeah.
Which I think is going to be devastating for a lot of people. But from your experience, how can someone say with a mental health problem, who's genuinely got a problem with functioning every day, they can't work, they can't go out, they can't function, because that's really hard to prove, I would have thought. So how, in your experience, how genuinely are people suffering from that? How can they get through an assessment, not legally, but genuinely to show, look, this is how I'm struggling?
So let's take, for instance, depression and anxiety.
Yeah.
So if somebody has a diagnosis of depression and anxiety, they see the GP and they're on antidepressants. They're monitored by the GP for side effects for that medication for the first 6 weeks they go on. And then in essence, they're discharged from the GP. The GP will just keep checking how they're doing on the medication. They're therefore classed as stable. Therefore, there is no impairment. If they're referred to for talking therapy, psychotherapy, or they're referred to a psychiatrist, then they're deemed as needing further care, further therapy. Therefore, they're not stable and it has an impact on their life. But if something comes in and you ask them, how often are you seeing your GP? Oh, he just sees me. Then there's no risk of harm, is there? There's no risk of suicide because your GP's not seeing you. They've not referred you to anybody else. Therefore, you're classed as stable. So there will be instantly no award.
That's crazy. That's a system problem. Most people can't get into your doctor. And antidepressants are overprescribed like massively, in my opinion, because it's easier to do so. Because there are patients who especially privately, who we say, look, antidepressants, let's just give it some time without antidepressants.
Yeah.
Try, talking like CBT or psychotherapy or hypnotherapy, whatever it might be, until you start being better. And in those sort of, initial 6 to 8 weeks, there might be some improvement, but they're still being assessed. So you're saying those kind of patients may well...
Instantly dismissed.
Okay. So that seems very unfair because it
is very unfair.
Because it's like if you're a patient and you can't get to your doctor, you're being on antidepressants, but no matter how you try, you can't get an appointment. It's what can you do? It's not necessarily your fault.
From speaking to you earlier, I work as a private psychotherapist. I work within EMDR. I work with trauma patients. I'm seeing NHS patients. I'm seeing NHS patients who have been waiting more than 4 years for therapy that are coming to see me and paying privately. I also work for Anxiety UK, and I get clients from them, and they're means tested, so they pay for their therapy because they belong to Anxiety UK. They get referred to me, and that's with what they pay. Because there is no the access to therapies is really, really low. It's really poor, and I'm even seeing NHS employed individuals who don't want to tell their employer that they're struggling at work because they don't want to be penalised at work, who are coming to see me. And they're employed by the NHS.
That's a big problem. Ironically, it's a massive problem in the NHS, right? If you need to have probably not even just the NHS, actually, it's quite scary to say that if you declare a mental health problem or whatever it might be, dare I say, at interview stage, it probably doesn't. Even though they shouldn't do, they say there's no discrimination, but really, the
individuals, it's a very difficult subject, isn't it? But the individuals that I'm seeing are not wanting to declare that they're struggling at work because they don't want to be managed out. They don't feel that they're getting support and being managed within the role. It's been used against them, and they're wanting to manage them out of the role. So I'm seeing NHS employees coming to see me.
Yeah, I mean, I suppose one big problem that people, I guess it was rightfully so, taxpayers, the government, is people faking it. Now, no doubt there are people doing that, right? And in some places, I'd like to think it's a small number, but I don't. Maybe but have you got any case stories where it's clearly someone has faked it essentially, or is trying to fake it? When how can you? Because someone who's not experienced, especially from a GP, I'm quite gullible, right? But this is where I wouldn't be the best assessor because I'm like, yeah, you can have it. You clearly, but it's not as simple as that, right? It needs you need to be inquisitive, but also you need to have emotional intelligence, and there's lots of things to it.
Yeah. So I've seen. You find with individuals with fibromyalgia, they are very embarrassed about the situation that they're in. They are 9 times out of 10 not believed. The first thing you hear is they are very uncomfortable about going to their GP to talk to their GP because they feel they're not going to be believed. If there was a test, and hopefully, as we know, looking at research, but hopefully there's going to be a test in the future, they're kind of like disappointed and relieved that they get the diagnosis of fibromyalgia, that they finally know that yes, there's something wrong. I'm being vindicated here. They're validating the fact that I'm not very well, but there's no test for it. But when you talk to somebody with fibromyalgia, very typically what comes up is they're very ashamed of the symptoms that they have, that they're wanting to do things with family members that they can't because of chronic fatigue and the pain. And they talk about the things that they want to do and can't do. I have seen individuals that fake it, and they tell you all the things they can't do, why they can't do them, and why they can never do them in the future. That's different. You can tell. But I never take it at face value because I might be wrong. So in those cases, I'll look further. I spend more time looking for the evidence to support it. because you've got to make sure that you get it right, because this is somebody's life that you're assessing. I've had individuals who have told me that they can't plan a journey. Mm-hmm. And then when you talk to them, they're a manager of a train station. Mm-hmm. And their first job that they do every day is if any train drivers go sick, they have to plan where those trains are going to go. A really complicated task, yet you're telling me you can't plan a journey. Mm. I had another chap who said he couldn't plan a journey, and then at the end of assessment and talking to him further, he was actually a paramedic that drove an ambulance. Mm. So not only would he have to drive that ambulance to where this road traffic accident was, he'd have to then work with the individual and then drive to hospital, yet he's telling me he can't plan a journey. Mm. I had a senior director for a pharmaceutical company tell me, who was a qualified pharmacist, tell me that he can't manage his own medication. Really? Mm.
Maybe you can inside. Why would, for example, in that role, specific role there, it's going to be a relatively highly paid role. Mm. Why would that person? I mean, I don't suppose you know, but what would be? I can see where people have maybe a low paying job and they want to maybe see if they can play the system basically. But I don't understand I have no idea. That baffles me, to be honest.
It does me. I have no idea why they would go through a system to try and claim something that they clearly, and in other areas as well, it's not just that one area, all other areas, when you look at it, think, well, that's not quite true, is it? Because of what you're telling me and the sports that you do. You're a golf player and you've won this trophy, etc. It doesn't fit with what you're telling me. But I've also... I went to a gentleman's house to do an assessment, and this chap had got schizophrenia, and he had real difficulties. And when I got to the house, I noticed that the stairs had got like an inch of dust on the stairs, and I'm thinking, when did you last go upstairs? Yeah. So then when we got talking, and I asked him about washing, have any problems washing? No, it's fine. Oh, he was really apologetic that he couldn't make me a drink, really upset that he couldn't make me a drink, because he said he got no milk. And then when we were talking, this gentleman was born with 2 club feet. He'd got real problems walking. Okay. But he didn't see that as a disability because he was born like that. So he said, no, it's not a disability. That's my ability to walk. And the buses that came were the ones that were on hydraulics. So if it wasn't a hydraulic bus, he couldn't climb on it because his mobility deteriorated. Mm-hmm. He lived with a family member who'd passed away. He hadn't been upstairs in 15 years. Mm-hmm. The bathroom was upstairs. There was a toilet downstairs, but his bath and shower was upstairs. So he was washing at the kitchen sink. So when I said to him, are you okay washing? And he said, yes. No, he wasn't. But that was his level, his ability. And he couldn't stand in a shower. If he did have a shower, he couldn't stand in it because he'd be frightened of falling. And then he would be very fearful of not being able to get out of a bath, and he'd have to have somebody else in the house in case he was terrified, in case he'd fall in the shower and drown. But he said he was okay, clearly not okay. So he was due lots and lots of back pay because he wasn't okay with his mobility when he said he was. He wasn't okay with that, and he wasn't okay with washing or other things that he was doing. But if I'd not been to the house, I wouldn't have seen that. So that gentleman would have missed out on what he's entitled to. And I saw many occasions like that, that you walked into somebody's house and thinking, well, you're not doing okay because you can clearly see you've not used that shower in a long, long time. But it's about how people see themselves and their ability. And people don't like the word disability because that was his ability. And he was proud of his ability to get out and get to the shops, but he'd struggled over the past few days, which is why he'd not got any milk in. Incidentally, there were days where he'd not eaten at all. Really? Because he couldn't get to the shop.
And also, especially in things like schizophrenia, that's a very difficult one. I actually think there's some conditions where it should be mandatory to go to the house. Absolutely. Because otherwise, schizophrenia being an example, it's impossible, right? Even some neurological things, right? I think it's actually impossible to prove it on a pen and paper, even with a like a consultation like this. What if somebody says, I've had this a few times on comments on previous videos where people have said they can't attend in person because of whatever reason, like they can't plan a journey, whatever. Yes, there might be some people doing that because they might want to say, look, let me try and do this because then they might think I can get the reward. But if someone said that genuinely because they can't, can they do a virtual one out from home, or is that not allowed, or how? Or do you have to go out to them, or because sometimes
I would go out to them.
You go out to
I would
them.
go out to them
Because a lot sometimes people have been asking about virtual one. I don't know the answer to that, because I would have thought that'd be a bit of a pointless exercise. I would have thought virtually, because it's hard to assess anything because you're just seeing them through a laptop screen. You can't see all the other cues in the house and things like that.
I think it's so important that you actually see them in person. You must be able to see them in person to gauge what's happening and to be able to build that rapport so that you do get to see a good picture. I saw more often than not people that were scoring low because they weren't given the right information and they weren't given the right evidence. They assume that we'll write to the GP and ask the GP. They don't. PIP don't write to anybody. You have to give all the information.
What effect did the lockdown have on all this? What was the process then? Because I guess in lockdown people were still living with disabilities, right, and not able to function or not able to plan journey and things like that. How is it assessed then, and what's the effect been now? It must be a massive backlog, I would have thought.
Yeah, there was a big backlog in the beginning when it went from when PIP first came in, there was a massive backlog. And then they when they were awarded the PIP, they awarded it for 1 year, 2 year, 5 years. It's those that are coming through now that are being looked at.
Really?
But if it was something where they didn't expect there to be any change, then that would remain the same. They'd just be asked to, has it increased, has it decreased, and they're not seen.
Oh, that's interesting. When someone says when is it reassessed for someone who has been awarded, the funds? Is it it's not the same for everyone, I'm guessing?
No,
right?
It's not the same.
Okay.
No, each assessor would put forward an expectation.
Okay.
If it's something, I can't think off the top of my head. If it's something that wouldn't change, if you're a paraplegic or something that would not change,
I see.
then that would just carry on going. But quite a few. If it was a mental health condition, if somebody was seeing a psychiatrist, then there'd be an expectation of maybe a year that they would be looked at again for when they've had the therapy.
Oh, interesting. And I have interest. What happens if because I've seen on TV, sometimes on social media where there's been some secret footage of someone running or cutting the grass, whatever, when they've been claiming PIP, right? And these are incidental. Obviously, this is not the PIP trying to catch them out. This is just them being exposed from whatever reason. Does the government or PIP do that intentionally? Do they carry out secret assessments of people they think are faking it, or not
that I'm aware of.
No. And what happens if someone who's caught essentially, having faked it? What happens to them then? Do they?
I'm assuming. I don't know, but I'm assuming it's the same as any other benefit. That if they're found that they've claimed something and they're not supposed to, then it's stopped, and then they look at whether they pay it back or not.
Oh, really? Okay. I would have thought that'd be quite a big deterrent for people, but I guess a lot of people think they can get away with it, right? Because it's, and I think that is the small percentage of people doing that. I think it will ruin the program. Because again, there's lots of things in particular around fibromyalgia, mental health, that people say is not real, people are faking it. In particular, fibromyalgia, actually. And every time I do a video about fibromyalgia on social media, there's always quite a few people actually saying it's a fake disease. People are making it up just so they can get benefits, right? But actually, the assessment seems like it's fairly thorough. But I think where the problem is it seems very inconsistent from one person to the other.
Yeah.
But the problem is that's going to be very hard to tackle. I don't know how you would do it. The only way which is not feasible, would be like assess someone over a couple of weeks with the same, one or two assessors, right? But how actually implementing that is quite difficult.
I think it's about time, taking the time to talk to people, to talk to the claimants, and I think they should only be assessed by mental health nurses, qualified members of staff, to look at fibromyalgia. And that's how I got my interest in fibromyalgia, was through looking at these assessments. And you can clearly see there's trauma there. There's trauma. They'll say they first started having, when you say, when did your symptoms first appear? Oh, well, it was after this happened or that happened. I started to get this and then it got worse. You can pinpoint trauma. So I knew even then there's trauma here. And then within my other roles, going into working within other nursing areas, and you're looking at people with anxiety, you can pinpoint trauma as well. You can see it. And then you look in the notes and you think, there we go, look, here, there. Look, and then, there we go, fibromyalgia, it's appeared. There it is, look. You can see it, you can track it.
Now, I must admit, the number of people, actually almost exclusively with patients I've seen with fibromyalgia, the number of patients who've had a traumatic event, in particular the first 18 years, 21 years of their life, it's quite it'd be interesting to do a study on this actually, but it must be in the high 90%, you know, I'd have thought,
absolutely.
around the amount of people who have. Now, ultimately, I still think the cause of fibromyalgia is likely an autoimmune thing that's triggered by an event, you know, that sensitizes the nervous system, and again, in later life, it sets it off, right? And I think that's what happens. Obviously, the full research is still, hopefully, is coming out soon, but it's very interesting because you mentioned earlier that you do a lot of EMDR, right? And I've been looking at a lot of other things that can help patients, in particular with fibromyalgia, or, you know, Ehlers-Danlos, or, you know, ME. And one thing that does, I'm looking at the papers, that does seem to help is EMDR. Now, people think that's only for something like PTSD. However, I'm seeing it a lot more, and I'm looking at the studies, it's showing it is actually beneficial if done properly for patients with, you know, an underlying trauma that's triggering their fibromyalgia.
Absolutely.
So everyone's probably heard of EMDR, but what actually is it? What does it involve, and how can it help?
So it's actually got a really poor name. So EMDR stands for eye movement desensitization and reprogramming. So the easiest way to describe it is we can have an event that happens to us in life. So I use car crash. So you can have two people can be involved in a car crash, and so what happens is you have the event and the emotion. So something happens. We go to bed at night, and we go into rapid eye movement, and during that, the emotion splits from the trauma, from what's happened. And then we decide with the memory whether to put it in short-term, long-term, or reject it. And the emotion is processed, and that's filed away. For some reason, the emotion does not split from the traumatic event. It's not programmed. It's not been processed, and it remains there. So it remains a trigger. So you can have two people in a car crash. One person, weeks later, can say, oh yeah, it was really bad. We're so glad we walked away. The other person is still really distressed, still brings up the emotion to it, and is very distressing for them. And that can go on to trigger other things because it's not processed. So it was actually Francine Shapiro in the 80s discovered by accident while she was walking in the park and was thinking about something quite distressing, that her eyes started moving. So in looking at that further, so that brought about the therapy of EMDR. So what we do is we can bring up that memory that's not been processed. We bring up the worst image, the worst part of that memory. We process it by following a ball or on a computer screen or the fingers from side to side. And we note the emotion, the memory. And there's always a negative belief that comes with it. So for instance, with a car crash, if I'd been a better driver, if I'd been a better person, then that wouldn't have happened. That car crash wouldn't have happened. And we process the memory. The emotions go down, the negative belief goes down, and it reprocesses it, and it fractures the emotion comes away from the memory, and that's how EMDR works.
So, for example, say if you're talking, so that's what I think is very important. So, say if you're talking to somebody and then they mention, let's say, the car crash when they were younger, and you notice their eye flickering, you know that's the event and that's the emotion. Then, or they show signs of distress, right? So either they start breathing a bit faster, or they're getting a bit obviously hotter or sweatier. Sorry.
Yeah.
So what actually does EMDR obviously involves moving your eyes in a certain way.
Yeah. So it's bilateral stimulation. So you can do it with eye movement, or you can do it with sensors that go from left to right.
Okay.
Or you can do it, if people can't bring up images, you do it with a headphone on, and it could be noise that goes from left to right. It's the bilateral stimulation that splits the emotion from the event.
So the event, the emotion they're feeling is obviously maybe fear or worry's going to happen again for the car crash. So that's how in a session do you tell the person to bring that up, and then at that time is that when they do the eye movements? Is it in a coordinated manner? Is it mandatory? Is it different for everyone how fast they move their eyes or squeeze the sensors?
We do it for 30 seconds.
Okay.
So you do a short blast of 30 seconds.
Okay.
Anything more than that, you can actually re-traumatise somebody.
Okay.
But you usually find that there's a connection to something else. So, for instance, I had an individual as a child, and as we spoken about earlier, it's usually between the age of up to 18 that you can find that there's some trauma there to begin with. So I had a young lady who she was 5 years old and went to a barbecue, and her uncle was having a laugh and thought it would be funny to dip her upside down in the paddling pool. So I held her by the ankles, and she's got her head in the paddling pool. Obviously couldn't do anything about it. Yeah. Pulled her up, everybody was laughing. She didn't find it funny, so he did it again. And until, because this is supposed to be funny, you're supposed to laugh. And obviously a child at that age being held underwater didn't find it funny. She then went on to have a fear of being around people because it's a traumatic response to that. She then went on to have a fear of being with other people, that they're looking for her response because of her response when she was in the paddling pool. And you end up with complex PTSD because then she's going into the workplace and she's her autonomic nervous system's going into overdrive, flight, fright and freeze, and she would freeze when she's talking to people. And that incident was the touchstone for all other complex things that were happening in her life until she couldn't actually leave the house. So with EMDR, it's really important to have a really good timeline, a history of what's happening. And we went back and that first memory was only brought up while we were doing the EMDR. It brought it up because it was a memory that was hidden but was affecting her. And then as soon as we were able to deal with that one, the rest just fell into place. And that lady got her life back and actually got on a plane and went on holiday.
Well, I think that story rings relevant a lot. And I think, so obviously that's things like PTSD and complex PTSD, which I think people understand, having a trauma, how it can manifest. But I think what people have a lot of, I don't understand is how can that relate to something like fibromyalgia? And we know now that, I've talked about this before, right? Where in the first kind of 21 years of your life, you're born with an abundance of neurons, right? Yeah. And your body's kind of thinking what it should and shouldn't keep. And if you're having a traumatic event, physical or mental, your body kind of remembers that, right? As a thing to protect itself. So later on in life, if something else triggers it, so it might be an episode of depression, for example. Yeah. The body can respond in fibromyalgia, for example, with pain everywhere. In chronic, ME, it might be just extreme fatigue. And we can deal with that, and we can deal with that with various things. But ultimately, what you have to do is go right back to find out what's actually underlying all this. And I couldn't agree more about the timeline, which is why when I see patients, the first thing I do is get a massive sheet of paper. Yeah. Start from even actually before they're born, about asking about their parents, right? What their mum was doing while they were in the womb, right? All the way to the present day.
Absolutely.
Because without that, there's no point. You can treat the fibromyalgia, right? But that's why I think it's over-prescribed medications for fibromyalgia, because it's not working, anything we're trying, but no one's actually gone back and asked, hang on. And this is where therapists, I think, are better than doctors actually, is going back. What actually happened? Like, why do you have this potentially? It's not the case for everyone. But again, I was saying before, we haven't done a study on this. It'd be interesting to do it. I'd say it's in the high 90% about how many people have had something.
Absolutely. Absolutely. And I mean, we know, it's beginning to look like, with the recent research, that what happens with the constant trauma. So when we have trauma and we have all the hormones and everything that's released, what we're now finding is cortisol has not been released at the end. There's a lack of cortisol when we go into flight, fright and freeze. And it's this that is switching on the autoimmune system, which is, we believe, is the cause of the fibromyalgia. As we know, we need more research on it. The individuals that I see that are coming with fibromyalgia and we are able to find the trauma and turn it down, they are telling me that the symptoms are going down. We are getting a reduction in symptoms, but we need a long study to see how effective it is. It's not a cure, but we're bringing it right down, and we can make such a difference with the EMDR. So there's definitely a connection.
I agree. There's no cure at the moment. I think that's a work in progress. But I think one thing to deal with the main cause is one, but there's lots of things you need to do, right? And I think fibromyalgia needs loads of things, right? One is dealing with the root cause. You need to have some kind of nutritional input, some kind of physical input, some kind of medical input. It needs to be everything, right? Yes. And ultimately, at the moment, people are just having maybe some medical input. That's it. And that's not going to do anything. That might at best just cover up your symptoms, but not really, right? And eventually you're going to need to high dose that medication or try different medication. So I think EMDR, CBT to some extent, somatic therapy, all these things are vital. But another thing that's really important, I think I've seen work really well, not just for fibromyalgia, is hypnosis or hypnotherapy. I had a lady come on a few weeks ago talking about it, but want to get your perspective on because I know you do hypnotherapy, right?
Yes, I do. Yeah.
But that's different hypnosis. So I shouldn't say hypnosis. They're two different things, right? Or stage hypnosis is everything's Darren Brown kind of thing, right? They assume you're going to make me do things I don't want, but it's more than that, right? It's actually a therapy to help with previous traumas or addictions and things like that.
Absolutely. Yeah. So I actually belong to BISCA, which is the British Association of Clinical and Academic Hypnosis. I think a really important thing to bring to the forefront at the moment is anybody can call themselves a hypnotherapist. You can read a book on hypnotherapy. There's no legislation around using the word clinical, and then somebody could call themselves a clinical hypnotherapist, advertise and see individuals with no medical background whatsoever. That's actually pretty shocking.
I think I mentioned I'm building like a platform, online platform, to help people with chronic pain and mental health problems. And part of that is having the best therapist, from around the world. And I learned very quickly that it's not just it's any therapist, that there's no kind of governing body or anything. So people can say they're a therapist. And now I've spoken to hundreds of them. Now I realise, okay, who are the right ones and who aren't. But initially I was like, this is crazy. Like if you don't know what you're doing, you could go see someone who you think is actually a therapist, but all they've done is essentially maybe a 5-hour course, if that, which is crazy.
Shocking.
Because especially with hypnotherapy, you could easily re-traumatize someone if you don't know what you're doing, right? Or
Absolutely.
I mean, people waste their money, right, as well, but you could cause way more harm than good if you don't know what you're doing. And it's a very, very, to do it effectively, you have to be very, very good and very, very well trained at it,
Yeah.
But what have you seen it work with? Interesting, because I'm very keen to speak to therapists who have used their modalities to help with chronic conditions, right? But how have you seen it work in patients?
Hypnotherapy is used as part of the EMDR. So when we want to emotionally regulate, we must have somebody emotionally regulated before we go into the trauma.
What do you mean by emotionally regulated? Do you mean they know?
Be able to be in a relaxed state, be able to recognise their emotions, and be able to bring them down. So we use a technique called special place, and it's a hypnotherapy technique where they can go in their mind to a special place that's a place where they are safe and able to bring the emotions to and be in a good place. And that's actually a hypnotherapy technique. So hypnotherapy is, and it's proven that you can actually turn pain down with it. So you can do a guided relaxation and a guided hypnotherapy session where you can turn the pain down. Our minds are amazing, but they don't know my mind doesn't know what's real and what's not. It can't tell the difference. So when we act things out, our mind will protect us and we'll think that it's actually real. They did an experiment where they hypnotised individuals in a gym. So they lay down in the gym and they imagined going on the machines and they tested their fitness levels. And they did a hypnotherapy session where they imagined running and on the rowing machine and everything. And then they had another group who actually did the exercise. And then when they checked the fitness levels, those that were hypnotised and went through their mind and thought they did it had an increase in fitness.
Really?
Yeah.
Wow.
Absolutely amazing. But they'd not done any exercise at all because their body responded thinking, oh, yeah, I'm on the running machine. So that's such a powerful thing to use if it's used correctly. We have, when I did my training at Birmingham University, and on that course were anaesthetists who actually use hypnotherapy before they go in for operations, during operations. It's amazing therapy and just so helpful. But it gets a bad press because it's not regulated. And that really must change. It needs to be regulated. The general public doesn't know the difference between somebody that's done an online course for 5 hours or somebody that's done it at degree level, and it can do a lot of damage. It's if you use hypnotherapy on an individual that's going into court to give evidence, it can mean that they are not able to give evidence. If they're a victim of crime and you do a hypnotherapy session with them, you can alter their memory of things. So it would mean they wouldn't be able to go to court. So that's how powerful it is.
Yeah, no, I think it's something that I'm looking more at, and I think I've seen it help, a lot. If anything, it helps control symptoms, right, and help control whether it's pain or anxiety, or whatever it might be. It definitely has some kind of relief, or toning down, the vagal nerve. It can do this, right, and I think it's a low-hanging fruit that a lot of people can potentially try. But again, like most things, it's something that has to be done regularly, right? And done to a high enough standard to be able to get an effect. You're not going to get an effect in one session, right? It takes time with these things. And I think that's where the NHS in particular, but a lot of time people fall down. So look, it's been an amazing conversation. I think if people want to, I'll leave all your details at the bottom of the video.
Thank you.
If people, obviously you do EMDR and hypnotherapy. If people want to find out more about you or your services, how can they find you?
Just Google me. Google Jacqueline Gozzard. I'm the only Jacqueline Gozzard in the country.
Really?
So you'll find me. Yeah, I'm the only one in the world.
Oh, really?
Yeah. My claim to fame is I'm the only Jacqueline Gozzard with 2 Z's in the world. That's me.
That's
so if you just Google me, it is true.
I'll actually Google this and check. But I'm sure you're right, but that's crazy. Okay, okay. Well, there you are. Very easy to find. So Gozzard with 2 Z's.
Yeah, Gozzard with 2 Z's. You know what a Gozzard is? It was the king's goosekeeper. He would say, "Bring me my Gozzard."
The king. Wow, I didn't know that. Really?
Yeah.
Wow, you're very easy to find now. But but honestly, thank you so much. I think I'm sure there'll be lots of questions from people about the PIP, and we touched on it briefly. Well, I say briefly. I mean, it's been almost an hour now, but it's a very complex topic, and I think there's going to be lots of questions about it. Lots of people are going to be disappointed about it, and I'm sure the government will upheave it all.
I'm absolutely heartbroken looking at this green paper that they're looking at the moment to remove fibromyalgia. I think that's absolutely appalling. Absolutely appalling. It's an awful thing to live with, and I've seen I've seen thousands of people with fibromyalgia. It's destroying their lives. It's awful.
I think it's bad for 2 reasons. One, yes, because obviously the direct effect is people not getting the benefit they need. But also, it makes just the general public, the perception of fibromyalgia not being real even worse. Like they think, they're taking off the PIP list. It's obviously not real, right? And I think that's the real damage. But what we want, if it is ever, changed or anything like that happens, we'd love to get you back on and get your perspective on it, because I think you've got a lot of inside information clearly, and you're honest enough to say it.
I find it so upsetting for people. If I had a penny for every time somebody said to me, "I've got fibromyalgia, do you believe me?" Do you believe me? Yes, I do believe you. I've seen. Yeah, I do.
I couldn't agree more. I think it's one of those things that needs more time.
Absolutely.
It's definitely real. In fact, I think it's probably one of the worst long-term conditions to have because of that reason. People don't believe it, which is even worse than having a condition that people believe, right?
Yeah.
But yeah, I think there is going to be a change, unfortunately, around the corner. And I think people will need guidance and support and questions. So if that happens, we'd love to get you back on just to get your perspective on it.
Absolutely.
All right.
Love being here.
All right. Thank you so much.
Thank you. Take care.
Thank you.